Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. In the previous video, we discussed dermatomes and the pattern of sensory loss caused by spinal nerve root involvement. A dermatome is an area of skin supplied mainly by one spinal nerve root. Therefore, when a single nerve root is affected, sensory loss usually follows a narrow, recognizable dermatomal distribution. For example, an L5 root lesion may cause altered sensation over the outer leg and dorsum of the foot. Sensation in unrelated dermatomes remains relatively preserved. This is because the lesion affects the sensory fibers belonging to that particular root before they join the spinal cord. The abnormality is therefore restricted mainly to the territory of that root. There may also be radicular pain, weakness in the corresponding myotome, and reduction of the relevant reflex. A sensory level is different. It is a horizontal boundary on the trunk where sensation is relatively normal above the line, but reduced, absent, or altered below it. For example, if pinprick sensation becomes impaired from the level of the umbilicus downward, this is described approximately as a T10 sensory level. The umbilicus is a useful surface landmark for the T10 dermatome. The important point is that a sensory level is not simply one abnormal dermatome. In a spinal cord lesion, sensory disturbance extends below the level because the long ascending sensory pathways carrying information from the lower parts of the body pass upward through the spinal cord. Consider sensory information coming from the legs. These fibers enter the spinal cord at lower levels and then travel upward toward the brain. If the spinal cord is damaged at a higher level, those ascending fibers are interrupted as they pass through the lesion. Therefore, sensation from multiple segments below the lesion becomes affected. This gives us the basic pathophysiological sequence. Sensory impulses arise below the lesion, travel upward through the spinal cord, encounter the damaged area, and fail to reach the brain normally. The patient therefore develops sensory disturbance below a horizontal boundary. Different sensory modalities travel through different spinal cord pathways. Vibration and joint position sensation ascend mainly through the dorsal columns. Pain and temperature sensation travel mainly through the spinothalamic tracts. Therefore, a spinal cord lesion may affect these modalities differently, depending on which part of the cord is involved. The apparent sensory level on examination is an approximate clinical level. It does not always identify the exact anatomical level of the spinal cord lesion. Pain and temperature fibers may travel up or down by one or two spinal segments before crossing, and spinal cord anatomy does not correspond perfectly to the vertebral level. The sensory level must therefore be interpreted alongside motor findings, reflexes, sphincter symptoms, and spinal imaging. The practical memory rule is simple. Dermatomal sensory loss suggests a nerve root lesion. Sensory loss affecting the body below a horizontal level strongly suggests a spinal cord lesion, or myelopathy. By this stage of a neurological examination, a patient with myelopathy may also have leg weakness, increased tone, brisk reflexes, clonus, extensor plantar responses, or an abnormal gait. The sensory level strengthens the impression that the lesion is within the spinal cord rather than in a single peripheral nerve or nerve root. Important causes include spinal cord compression, transverse myelitis, spinal cord infarction, multiple sclerosis, and trauma. The clinical context helps separate them. Back pain, local spinal tenderness, malignancy, or progressive symptoms may suggest compression. Rapid onset may suggest infarction. A subacute inflammatory presentation may suggest transverse myelitis. Relapsing neurological episodes in a younger patient may suggest multiple sclerosis. In PACES, a professional way to present the finding is there is a sensory level to pinprick at approximately T10 with impaired sensation below this level. This is suggestive of a thoracic spinal cord lesion causing myelopathy. A newly developed sensory level is an important warning sign. When it is associated with leg weakness, gait deterioration, urinary retention, incontinence, or bowel dysfunction, urgent spinal assessment and imaging are required to exclude spinal cord compression. Remember, one dermatome points toward one nerve root. A horizontal boundary with sensory disturbance extending below it points toward the spinal cord. Do subscribe to the channel for further videos.